Hi, my name is Caprice Rengifo and I'm going to talk about permissive underfeeding or standard enteral feeding in critically ill adults. Definition: nutritional support is an essential component of the care of critically ill adults. Achieving caloric targets has been recommended with the premise that attenuating malnutrition and protein catabolism, which are associated with increased morbidity and mortality, will improve outcomes.
Welcome to Metabolism Matters. I'm Jennifer Woolley. Today we'll be talking about feeding critically ill patients. Feeding critically ill patients isn't easy. This is because acute illnesses can stress a patient's metabolism and make it difficult to anticipate their caloric needs. To emphasize the difficulty in calculating a critically ill patient's caloric needs, let me share this fact. Did you know more than 50% of ICU patients wind up malnourished? When a patient suffers from malnutrition, they can become dependent on the mechanical ventilator. This means they will be in the hospital longer, which increases morbidity and mortality as well as costs. The dietitian's job is to protect patients from malnutrition by providing proper nutrition intervention, and luckily, there are tools to help the dietitian do just this. One tool is predictive equations to estimate energy expenditure. As an example, this is the Harris-Benedict equation. Predictive equations are often used because they are convenient and inexpensive. Unfortunately, they have many drawbacks. There are hundreds of equations. There is lack of consensus about which equations are the best to use, which leads to significant practice variation. And they are only accurate less than 40% of the time. Less than 40%? Let's get another tool, shall we? Let's look at indirect calorimetry. First of all, what is it? Indirect calorimetry uses inspired oxygen consumption and expired carbon dioxide production to accurately calculate energy expenditure. The coolest thing about indirect calorimetry is it's a measurement, not an estimate. It's also objective and accurate because it's tailored to each patient. And it's not just me saying that. According to the Society of Critical Care Medicine and the American Society for Parenteral and Enteral Nutrition 2016 guidelines for the provision and assessment of nutrition support therapy in the critically ill patient, indirect calorimetry should be used to determine energy requirements when available. That means if you've been asked to follow SCCM and ASPEN guidelines, you should be using indirect calorimetry. So the next question people ask is, what are the equipment options for indirect calorimetry? Equipment options include metabolic carts, handheld or tabletop devices, or, and I find this to be the easiest, an indirect calorimetry or airway module built into a mechanical ventilator. Well, that's it for today. I'm Jennifer Woolley for Metabolism Matters. See you next time.
Application in medicine. In the past year, many studies have documented the importance of early enteral nutrition support, endoscopic placement, or post-pyloric nasoenteric feeding. Tubes is being used more frequently to establish early, reliable enteral access and allow early initiation of enteral nutrition in intensive care unit patients.
A chest X-ray is now required to confirm placement for any tube that is going to be used for administration of medications or enteral feeding formulas.
This includes existing tubes currently being used for decompression if any medications are given via the gastric tube.
Confirmation of placement needs to be obtained from a physician before administrating any medications or fluids.
Remember to document the size, type and external length in the Cardex, nursing flow sheet and in the plan of care.
If you are using an open system for enteral feeds, you will need to change the bag and the tubing every 24 hours.
For a closed system of enteral feeds, the bag and tubing needs to be changed every 48 hours, or upon completion, whichever comes first.
The enteral feeds do not need to be stopped for personal care or repositioning of the patient. A new enteral feed PPO needs to be completed with new feeds. The head of the bed is to remain at 30 to 45 degrees, unless the patient is being repositioned.
When hanging a new bag, whether it is an open or closed system, the bag should be labeled with the patient's name as well as the date and time.
Routine water flushes are to be done with tap water, and commonly are 50 milliliters every 4 hours. When preparing to give medication via the feeding tube, be aware that each medication is to be crushed individually and mixed with 30 milliliters of tap water. The feeding tube is to be flushed with 15 cc of tap water before and after administration of medications. Remember to monitor the fluid balance. Use sterile water to mix any enteral medications for patients that are critically ill, immunocompromised, or under 1 year of age.
External length is to be measured and documented every shift.
The 60 cc syringe and water container are to be replaced every 24 hours.
Pros and cons. The pros is caloric restriction may be beneficial. It has been shown to prolong lifespan in several species, promote mammalian cell survival, and improve longevity biomarkers in humans. Another one is that among critically ill patients receiving parenteral nutrition, lower morbidity and was observed with the hypocaloric nutrition than with standard nutritional support. The cons is the 90-day all-cause mortality in the ICU, and infections happens in the ICU. 90-day mortality of 25% with standard feeding. In other occasions, it causes feeding intolerance and diarrhea. And the other benefits and cons we'll see in the video. Minimizing tube feeding intolerance.
Immune response. When compared to other forms of nutrition such as parenteral, enteral nutrition proves to be less invasive, less expensive, and much easier to manage from a fluid and electrolyte standpoint. There are multiple reasons that early enteral nutrition is beneficial in the ICU patient. It maintains gut barrier and immune function. It provides a valuable energy and protein source to preserve lean body mass and support the metabolic demands of critical illness. Early enteral nutrition is associated with reduced incidence of infection. Early enteral feeding reduces days on mechanical ventilation, length of stay in the ICU, and significantly reduces mortality. Issues that may cause a delay in feeding or inadequate delivery of feeding include hemodynamic instability, mechanical obstruction, or feeding tube issues such as clogging, misplacement, or inadvertent removal of feeding tubes. However, the most prevalent issue preventing adequate early enteral nutrition is intolerance. Feeding intolerance is defined as one or more of the following: elevated gastric residual volume, increased abdominal girth or abdominal distension, vomiting, subjective discomfort, diarrhea. Intolerance is experienced by 30 to 60% of ICU patients and accounts for 1/3 of all enteral nutrition cessation. The highest rate of intolerance is seen in cardiovascular, GI, and septic patients. We want to prevent intolerance by minimizing contamination. Hand washing is fundamental to safe patient care. Gloves should be changed frequently. We should change our gloves after checking gastric residual volume so that bacteria is not transferred when we are reconnecting tube feedings. Proper placement and removal of personal protective equipment is essential for preventing transfer of microorganisms to the nurse or other patient.
Complications. So let us to think a bit differently and outside of the box. And we're actually presenting some data later this afternoon in a session on what I refer to as the PEP-UP protocol, where we're trying to take us to a higher level of performance with these feeding protocols. And we're leaving behind the cautionary, reactionary, slow approach to enteral nutrition and jumping into a new set of ideas. So the first set of ideas I wanted to communicate to you is that not all critically ill patients are the same, and so we shouldn't really have one approach to feeding them. This 25 cc's an hour slow ramp up, perhaps isn't best for hemodynamically unstable patients or patients with recent foregut surgery. And so thus, perhaps allowing for a trophic feed where you give a lower dose of a semi-elemental solution for that first 24 hours would mean that we can better feed them without keeping them NPO. So now we have a series of options in this PEP-UP protocol rather than just feed or no feed. We enable them to choose trophic feeds. We use a semi-elemental solution as our go-to solution just because it's much more likely to be absorbed, particularly in the early phase of critical illness in these sick patients, particularly those that are hemodynamically stable. We do not use the 25 cc's an hour anymore, but rather we go right up to goal calorie. And moreover, we shift the goal from an hourly goal, 80 cc's an hour, to a 24-hour volume goal, so that you might get 1,500 mLs over 24 hours, and then let the bedside nurse figure out at what hourly rate he or she has to run it at to achieve that daily goal. Because as you know, there are interruptions to feeds. They go down to the radiology suite for 4 hours and the feeds are withheld. What happens when they come back? They start them back up at 80 cc's an hour. And we miss that opportunity to feed our patients adequately. So with a new concept of a daily target, then the nurse can double up the rate as needed to make up for those gaps. Tolerating a high gastric residual volume and starting empirically at time 0 with motility agents and protein supplements is another proactive.
Issue applying a color. Adequate nutrition therapy is crucial to optimize outcomes. Currently, there is a paucity of such data in Latin America. We conduct a cross-sectional retrospective observational study in the 8 Latin America countries: Argentina, Brazil, Chile, Colombia, Ecuador, Mexico, Panama, and Peru. Eligible patients were critically ill adults hospitalized in the ICU and receiving enteral nutrition and/or parenteral nutrition on the screening day and the previous day. Evaluation of nutritional status showed 74.1% of the patients had suspected moderate or severe malnutrition according to the subjective global assessment.
Much better feed our ICU patients. And of course we have to take into account that we may not overfeed our patients, but using early enteral nutrition, it's almost impossible to overfeed the patient and we can preserve the condition of the gut. So my first aim is to give my ICU patients some enteral nutrition and to target full enteral nutrition in the first 72 hours. If that's not feasible, and we know now due to recent studies that have been published, that if we not achieve these goals after 5 or 7 days, we can add some supplemental parenteral nutrition. But my main focus still will be use the gut when it's possible to use, and I feed through the stomach. And we can do much better. We know we feed them almost 70 to 80% of target, and that must be better in the future.
Conclusion. In conclusion, a strategy of enteral feeding to provide a moderate amount of calories to critically ill adults in the presence of full protein intake was not associated with lower mortality than a strategy aimed at providing a full amount of calories. Thank you.